Before we jump into this episode, I want to remind you that while Caitlin and Sophia are dietitians, we're not your dietitians. This means the information shared in the Food Freedom Fertility podcast is intended to entertain, educate, and inform. It is not a substitute for medical care. This information is not intended to diagnose, manage, or treat disease. Always consult with your doctor before making any changes.
Hey there, it's Kaylee Hunt again, the Food Freedom Fertility's podcast editor. This week, we will be re-releasing another older episode that was a fan favorite. This episode was a favorite because it talks in depth about PCOS lab work you should get done. Whether you are at the start of your PCOS journey, suspect you have PCOS, and want to do more in-depth testing, or wanting to reset and see where your labs are at, this episode is perfect. Both Caitlin and Sophia give a wealth of knowledge to how to ask for these tests, what to look out for with results, and why you should ask for these tests. We hope you enjoy this episode during the show's season break.
Welcome to another episode of Food Freedom and Fertility. We are your hosts, Sophia Pavia and Caitlin Johnson. We are both registered dietitian nutritionists. We are both specialized in functional medicine for women's health and fertility, and we are both pumped to be here. This is our last episode of the season. I'm beside myself that we're wrapping our second season today.
It's pretty exciting, and maybe I always think we do this at the end of the episode, but we're recording in like a new studio today because next season, we're going to make video available of our podcasts. So you can YouTube us. You can like hang out in the kitchen while you're cooking, and you can see our weird facial expressions and mannerisms and all of it. It's going to be so good. So that's exciting.
And you can see the little stuff that we talk about. And, and you know, when I'm like, look at this, like you can look at
this Santa thing that it's horrible.
Oh, God. Yeah, we threw that away, actually.
Finally. Okay. You can't see that, doll. People.
And listeners, what's really important also is we are going to have closed captioning and a full transcript on our episodes.
Yay.
For those of you that are hearing impaired, hard of hearing, deaf, for those of you that are better at reading English than you are listening to English, we will have you covered with captions and a transcript. So this is going to make it a lot more accessible for our wider audience. So we are really happy to be doing that because that is very important to do.
Yeah. So today, what are we going to talk about?
Today this is kind of like a listener request episode. This is a topic that we have had our listeners requesting to hear. It is going to be me interviewing fine young Caitlin here and asking her, learning all about labs for PCOS. So we are going to learn about which labs you should be talking with your doctor about, why. And Caitlin's also going to sort of give us an insight into the context of these labs, because when it comes down to it, we are treating the woman, not the labs. So just going into your doctor and saying, test my hormones, quote unquote, it's just it's a futile endeavor. You need to be giving context. You need to be giving symptoms. You need to be giving there maybe needs to be some diagnoses. You need to be looking at labs in context of each other. So if we're just to like look at your FSH, it really doesn't mean much to us. We want to look at it comparison to your LH. We want to look at it for what day you are in your cycle. We want to look at it in comparison to your AMH. So all of these kinds of things we're going to go into today so that you can be empowered, you can be ready, you can be the expert on you when you partner with a medical professional to start digging deeper into what your blood work might be telling you.
And the other thing I also want to add in is that we'll kind of talk about the labs that, you know, for each lab, we'll talk about what doctor might be most likely to say yes when you request them, and options if you approach hurdles in these requests, like what you can do to advocate for yourself to get these labs so that you can just be more informed. At the end of the day, this is just data, and data helps us make decisions. It's not a reflection on you. It's not a reflection on your efforts. It's just data that can help inform interventions that we will employ to help you get more fertile, better ovulation, higher progesterone, more chances at pregnancy, etc.
And just a healthier body overall when you have PCOS.
Amen.
Because PCOS is not a fertility condition. It's not a gynecological condition. And we need better parameters than just, oh, have you lost weight? Oh, good. Then your PCOS is under control. Like we need some other parameters to be looking at. Because if we're only looking at, did the number on the scale move? Am I pregnant? It can be very frustrating. But when we're making nutrition changes, when we're making lifestyle changes and start seeing things like my labs are getting better, things are improving in that way, because those are going to sometimes that's going to happen first. And then we'll start seeing your body making changes. All right. So Caitlin, when we talk about labs for PCOS, like why don't you just sort of start at the beginning? What do you think about? What are sort of like the first line things to begin with when it comes to labs?
So when it comes to labs, your doctor to even diagnose you, if you've had a recent diagnosis, is typically going to be looking at things like your androgen levels. So to obtain a PCOS diagnosis, you either have to be anovulatory or oligoovulatory, so ovulating less often or not ovulating at all. You need to have a picture of polycystic ovaries. At least one of your ovaries needs to look like that in an ultrasound. And then the third criteria, you need 2 of the 3 of these. The third criteria is either physical symptoms or lab work that shows hyperandrogenism. So the physical symptoms you could see are things like hair loss, or growing thick facial hair or hair down your neck or navel or on your nipples. It's typically down like the midline of your body. So it's not going to be like, really gross pubic hair on your arms. It's probably your like Italian heritage or whatever. It's going to be this more male-centered hair loss and hair growth down your midline. So your doctor may have ordered things like testosterone, free testosterone, DHEAS, which these are androgens that we typically test for. Or you may have just shown such a symptom picture that they were like, you check all the boxes. We don't even need to look at your hormones. We know that this is a scenario where we have high androgen levels.
Yeah, that's like the super classic PCOS.
Very much so. What I don't often see is really thorough testing to help us dictate what interventions you would choose. So part of that comes with a very traditional primary care doctor or OB. The reason why they're not doing extensive testing is because it's not really going to change what they're going to do with you. They're going to say, you have PCOS. What are your goals right now? Oh, you're not trying to get pregnant. Here's birth control. Oh, you are trying to get pregnant. Here's letrozole or Clomid, so that we can stimulate ovulation. Knowing whether you have high testosterone or not is not going to change that offer. Likewise, if you have a bigger body that you're in and weight loss is a recommendation from the doctor, they're not typically going to pull your fasting insulin to say, oh, you have high insulin levels. They're just going to prescribe you metformin. So oftentimes I see gals come in with a PCOS diagnosis that are ready to try to conceive, and they're just not getting thorough lab work because the doctor's just going to give them what they're going to give them. But I think that thorough lab work has a lot of applications. First of all, it can be really encouraging after you've been making a lot of changes to check back in and see like, hey, my testosterone levels are coming down, or hey, my level of insulin resistance is coming down. To be able to show that on paper when maybe you're not pregnant yet can be really encouraging and can kind of give you extra wind in your sails to keep you motivated to keep moving forward. So there's a lot of reasons and applications to consider lab work when you kind of step out of the conventional care model, like I'm going to the OB and I'm just going to do what the OB says, and you want to step into an alternative care model or an integrative care model where we're looking a lot more at root causes and holistic treatment. Holistic treatment is a kind of a term that gets thrown around, and I think people think when they hear that, oh, that means we're going to do things like herbs. But what we're really looking at is a comprehensive approach. Let's support your thyroid and your adrenals. Let's support your ovaries and your pituitary gland. We're not just going to shut down a process to make symptoms go away. And
yeah, think of the word holistic like WHOLE, like whole, like the whole woman.
Exactly.
It's not spelled that way, but I like to think of it that way when we're thinking of what's the whole picture, not just, oh, your ovary has cysts, let's shut her down. Or like, oh, you're growing extra facial hair, let's shut it down with some spirulactone or something like that. We're looking at, well, what's driving these symptoms and how can we mitigate that versus just shutting down the symptom itself, the whole woman.
So looking at really common labs that I think anyone with PCOS should be checking in on, this becomes even more important when we're talking about trying to conceive and lowering risk of pregnancy loss and just improving pregnancy outcomes, period. Things that I like to look at are, what is your fasting blood glucose level and what is your fasting insulin level? Your doctor will likely pull your fasting blood glucose as a part of a comprehensive metabolic panel, but they're not likely pulling your fasting insulin. This becomes important because you can take these two figures and calculate something called the HOMA-IR score. And this score is kind of like, think about
metric.
The BMI scale. It just gives us, it gives us a general idea and can zoom in a little bit more closely before fasting glucose levels or even something called your A1C come up high enough to say like, hey, you're pre-diabetic or hey, you're diabetic. There can be insulin resistance underlying for years, even decades, before things get so extreme that you would require a diagnosis like prediabetes. But we can see that a little bit more clearly when we look at the HOMA-IR score. So if you're listening to this, we'll put this in the notes. You can go to a page, I had it pulled up. If you go to www.thebloodcode.com and then you do /HOMA-IR-calculator, you can actually take a fasting blood glucose and a fasting insulin and calculate your HOMA-IR score. I think that this is so helpful. I was just looking at labs the other day where somebody's fasting blood glucose.
Extremely helpful. I do this even with women without a PCOS diagnosis.
Amen. It can be really helpful. So I was looking just the other day with a client whose fasting blood glucose had not changed very much, yet their fasting insulin had changed. It had gone from like 20 down to 12. And that is showing us, even though your blood sugar level may not have changed drastically, your body in both cases was able to maintain a regular blood glucose level, blood sugar level. It took almost half the amount of insulin to do it. And in somebody with PCOS, insulin is a huge driver of complications and other hormonal imbalances because there's kind of a signaling error that happens at the ovary level that when the ovary is super exposed to insulin, it produces a lot more testosterone. And that can stop ovulation. It can make your hair fall out. It can make you more likely to gain weight in your abdomen. There's like so much interplay there. So being able to see progress in those insulin levels is super helpful.
A lot of insulin can be believe it or not, it's an inhibitor to successfully using progesterone. So when we see someone who I would consider progesterone resistant, meaning that we look at their actual serum level of progesterone and it's looking decent, but their symptoms are showing us their progesterone is low, that's where I go hunting for what is this insulin up to. Because having a lot of insulin in your bloodstream at the same time as progesterone, like after ovulation, it's going to inhibit your body's ability to use that progesterone. And data shows it also inhibits your corpus luteum's ability to produce progesterone at the same time. So if I'm seeing low progesterone or I'm seeing what I would consider progesterone resistance, that's where I'm also looking at that HOMA-IR score. And it can really be a 1-2 punch for women with PCOS because we're looking at an ovary that was struggling to ovulate in the first place, and now it finally did, but now you have these potential progesterone problems because insulin is like gumming up the works.
And when we're talking about progesterone, this is progestate. This is like we're going to keep a pregnancy alive hormone. And so it's really important that your cells, especially in the uterine lining, are receptive to progesterone to prepare for implantation and to continue the message that we need to hold on to this lining because we have now an embryo that we're trying to keep alive. So HOMA-IR, this is like the basic. If you cannot talk your doctor into pulling blood glucose, a fasting blood glucose, and insulin together, so we want them from the same day, same time point. We don't want to use fasting blood glucose from your annual and then you got them to pull a fasting insulin. We want them from the same day. If you can't get them to pull those two together, you need to shop for a different doctor because this is like the most basic information that can be really helpful. So I think of that as really primary. I also want to look at vitamin D. I want to see, are we in really dire straits where your vitamin D levels might be in the 10s or 20s? Or are we doing okay, maybe in the 30s and 40s? Or are we in an optimal range like 50 plus, 50 or 60 to 80? That's where we want to see you, unless you've been listening to us for a really long time, intentionally supplementing, working on your magnesium levels. You likely need more vitamin D. So that's something that I would say is worth testing at least annually. So vitamin D, fasting blood glucose, fasting insulin, and then I also want to look at, in a very basic panel, at least your TSH. Now, that's literally something that should be looked at every year at your annual visit. However, when we're starting to talk about fertility, it becomes considerably more important, especially with PCOS, because as TSH levels climb above 2.5, we see increased risk of miscarriage. So we want to work on kind of looking at these parameters pre-pregnancy. How is your blood sugar and your insulin functioning? How much of an issue is this that we need to manage or intervene right now in order to help you get pregnant? And then what is that going to look like later on? We want to look at vitamin D and TSH because these are really good indicators of if we're going to struggle with a higher risk of pregnancy loss. Then as I zoom out a little bit further, I want to start looking at how are your ovaries doing in terms of their estrogen production or their testosterone production. And this basic question, how is your ovary producing estrogen or testosterone? It's kind of like if you can answer one, you can almost always answer the other in the context of PCOS, because your ovary will kind of be pushed towards producing testosterone in that hyperinsulin, that high blood levels of insulin state, and it will do that at the expense of estrogen. So you can actually have high levels of testosterone when you want high levels of estrogen, and both of those things are really working against you. You can have high levels of testosterone and low levels of estrogen, and it's happening at the expense of one another, and they're both kind of working against you. So when you ask your doctor, hey, I want to zoom in a little bit more closely, and I know that this might not be something that you necessarily look at for what you're going to do, but I just want a bigger view into what's going on at the ovary level so that I can set myself up for the easiest chance of conception and holding on to a pregnancy. Asking if you can test simple, very common hormones, estrogen and testosterone, can give us a really big view. And from my perspective and Sophia's perspective, this can be really helpful in choosing what type of interventions we're going to employ. We're likely going to be looking at a big bucket of what are we going to do to support your insulin resistance already. But how much of a problem is this overproduction of testosterone for you? This varies among PCOS women greatly. We might find that you make a lot of estrogen and you're doing okay with your levels of testosterone. Sophia and I are going to offer different supplementation to you, or we might offer something like spearmint tea versus going into something a little bit heavier hitting like a licorice. So it can really impact what type of intervention you're being offered by more of a functional medicine practitioner. So then I like to kind of say like, okay, have we looked at the basics? We've looked at insulin, we've looked at blood glucose, we've looked at estrogen, and we've looked at testosterone. Have we looked at just the basic things that we want to make sure are healthy and in good standing before we go into pregnancy? So what do your lipid labs look like? How are your liver enzymes? These are things that would show up on a basic kind of annual physical type blood lab request. So your doctor is usually going to order something called a CBC, a CMP, so that CBC is a complete blood count. A CMP is a comprehensive metabolic panel, and they're likely also going to look at a lipid panel. In your CMP, we're going to be able to look at liver enzymes. Part of why looking at your lipid panel, so looking at total cholesterol, LDL, HDL, ratios within that, and looking at your liver enzymes, give us an idea on how your liver is functioning. Your liver is like your heart and your lungs and your brain. One of these stops, things don't really continue for you, right? And I think the liver is kind of like this thing that we don't really talk about as often as we need to, because your liver has a great amount of interplay with how you get rid of hormones in your body, but also how you're recycling your cholesterol. And cholesterol is a key component for hormone production in the sex hormone piece of kind of the hormonal picture. And fatty liver disease is something that's really common in women who have PCOS, especially if there's a high level of insulin resistance. So we want to know about these things in a kind of fertility workup, pre-pregnancy, preconception period of your life. If we need to work on helping improve your liver health, that can really change outcomes in your pregnancy. So these are things that you should be able to say to your doctor. If you haven't had an annual physical, I would be shocked if your OB wouldn't just go ahead and order a CBC and a CMP and a lipid panel for you. These are relatively inexpensive. Like if I pull a CBC for somebody, it costs like $7. So nobody should flinch at you requesting these things. There are other things that Sophia and I recommend all the time that we get more pushback on. What are things like that for you, Sophia?
Oh, progesterone
Yeah,
every day.
progesterone's a high
Doctors
one.
are like, it doesn't matter. It changes. And listen, it does change. It does change. Your progesterone changes day to day. It changes hour to hour. It changes. It's supposed to change. But that is a far cry from meaning it doesn't matter. And I think that a lot of times, just like what Caitlin said at the beginning of this, when your doctor is, you know, if you're at a traditional OB or traditional reproductive endocrinologist, they have their certain set of tools in the tool chest, and they are testing to figure out which tool to use. And when you're a hammer, everything's a nail. So they're only going to look for things that are nails. And Caitlin and I have different tools in our toolbox. And so we like to look at things that we know how to treat and have seen a lot of success treating. And the other thing about it is, you just want to put this out there so you guys can understand when it comes to labs and what's quote unquote evidence-based, because your doctor, you know, as you're listening to these things that Caitlin is saying, your doctor might give you this thing, well, that's not evidence-based. And you know what? That might be right in some ways, because it takes an average of 18 years for the data to line up with medical practice. And you know what? Caitlin and I don't have 18 years to wait. And when we're looking at something that has as low of risk as like taking some damn myo-inositol or eating less rice at dinner, we're willing to take that risk. We're willing to prescribe these interventions without like peer-reviewed data that's made it all the way to the Mayo Clinic and is now their standard of care, and so it's going to trickle down to the rest of the hospitals in the U.S. We don't really want to do that. So if your doctor is kind of like, well, who told you this? This isn't really evidence-based. Guilty as charged. Fine. I disagree in the way that we can say there actually are many articles in many studies that show that these things are healthy, good, and effective, but it just hasn't made it to the mainstream yet. And we're fine with that. I don't mind being accused of that when I say that I want to look at your progesterone, or Caitlin saying she wants to look at your HOMA-IR, or wants to look at different parameters of your testosterone, like maybe not just total, but looking at free testosterone, looking at your sex hormone binding globulin, looking at a few different factors.
And before we dive into those, let's hear from our sponsors. All right, before we get too deep into this episode, we have something we want to talk about.
Caitlin, do you love getting your blood drawn?
No, I absolutely hate getting my blood drawn, and I don't love going to the doctor either.
Samesies. And thankfully, our partners at Prove have created a workaround for that.
So going to the doctor and getting your blood drawn, that can tell you some things. But do you know what? Your urine can tell us some stuff about your hormones as well.
And it can do it on your timeline. You don't have to wait for an appointment. You don't have to wait for a doctor to say, okay, now's the time we can start looking into this. You could go to Prove's website right now, order these strips, and start seeing your urine hormones today.
I know what you're saying. You're saying, I have pregnancy tests at home. I have ovulation predictor kits at home. But did you know that your urine can tell us more than just, I might be about to ovulate, or yes, I'm pregnant?
Prove has a strip that can test the metabolite of progesterone in your urine. It's called PDG. And that's what supports implantation in pregnancy. And Prove tracks this hormone during your implantation window. In fact, a clinical study showed that sustained and elevated PDG levels during the implantation window was associated with a 75% increase in successful pregnancies.
We're not just interested in getting pregnant, we are interested in staying pregnant. And Prove has a lot of resources, both in their testing kits and in their online app, where they have further resources for science-backed supplements and connections to fertility doctors, online education, and so much more.
And right now, Prove is offering you, our listener, 15% off your purchase with the code FFF15.
And now back to our episode. Let's hop into sex hormone binding globulin, because this is, it is an undervalued lab marker. It gives us, in the context of PCOS, it gives us two things. First of all, sex hormone binding globulin is a protein that your liver makes, okay? It has great impact all over your body because it does exactly what it's called. It binds sex hormones. And I like to think about it as like when Mrs. Pac-Man goes around and gets like one of those special dots at the very corner of the screen, and now she can like go and eat all the ghosts for a second that normally would hurt her. This is what sex hormone binding globulin does. It like goes and gets the ghosts. It like turns off the power of those ghosts, right? It turns off testosterone. So it goes around, it gobbles up the testosterone, and essentially it's kind of like putting Play-Doh around a key. The key won't go into the door lock anymore on the edge of your cell. So the testosterone, the key, can't do what it does. It can't float around your chin hair and make it coarse and wiry and thicker. It can't float around to your scalp and say, make that hair fall out. It can't touch the follicle and the ovary and say, hey, stop maturing, things aren't doing great. And so we actually want really high levels of sex hormone binding globulin. But there's this kind of interplay that as insulin levels go up, it is opposite of sex hormone binding globulin. So the more insulin levels, the more your liver is bombarded by insulin, the less sex hormone binding globulin it makes. So as we have low levels of that, you can't really turn the ghosts into edible things. They're bad for you. They're going to hit Mrs. Pac-Man and make her grow chin hair. All right. We don't want that for Mrs. Pac-Man. She's a Mrs. So sex hormone binding globulin, like the liver enzymes, like the lipids, give us a view of what's going on with your liver and can kind of give us a view what's going on with insulin resistance in your body. So specifically when we look at these things, I'm going to throw some numbers out at everyone. We're going to back up a little bit when we talk about fasting blood glucose and insulin. We're going to talk about vitamin D, all the ones we've covered so far. I'm going to give you some ranges that we like to see these figures in. So you will see on your blood, kind of the printout, they're going to give you a value for what your lab is. And then they're going to give you a typical range, okay? The typical range doesn't mean it's the optimal range. So when we talk about fasting blood glucose or fasting blood sugar, we want to see this number under 90 milligrams per deciliter, okay? This is not what the lab sheet's going to say. They're going to say under 100. Okay, so optimally, we want to see you at least under 90. 90 to 100, okay, we could probably see that improve. 100 to 125 is pre-diabetic state. So if you're consistently getting levels over 100 but under 125 as fasting blood sugar, this is too high for good health, okay? It's definitely too high for going into pregnancy the best that we can. And so we want to work on getting this level lower. There's lots of ways to do that. This isn't the episode for how to do that. Listen to every other episode we've ever made. When we're talking about fasting insulin, listen to the range here. Anything between 2 and 22 is a very normal insulin level. Even in some lab ranges, you'll see it up to 28, okay? That is a wide range. 2 to 10 is, in my opinion, a lot better, and we'll see pretty typical HOMA-IR scores with that. As soon as we start getting into the teens, and certainly by the time we get into the 20s, I don't even have to look at your HOMA-IR. I know you're going to have higher levels, and we're talking about at least intermediate or advanced, like pretty severe insulin resistance at that point. Might not be pre-diabetic yet, but it's enough that I know it's affecting your ovary and what your ovary is doing to produce testosterone. So if you have a level that's under 90 in your fasting blood sugar, your fasting blood glucose, and you have a number in the teens for your fasting insulin, we're likely going to need to be pretty persistent with interventions that are going to help insulin resistance. If you're in the 20s or higher of fasting insulin, we're going to need to be really aggressive. We're working on diet, we're working on exercise, we're adding in multiple supplements typically. Sometimes we're even using something like metformin. And so seeing these ranges can really be helpful in deciding what interventions. You're going to hear that throughout this whole episode. So again, remember that blood code, thebloodcode.com/HOMA-IR-calculator, and you can calculate your own HOMA-IR score with these lab values. There is something called an insulin assay, where they basically take a solution that's similar to if you've been pregnant before when you go in and test for gestational diabetes. You drink a certain amount of glucose, and then instead of just testing your blood glucose at different points, they test your blood glucose and your insulin. So we look at before you take the sugary drink, we look at 30 minutes later, 60 minutes later, 2 hours later, and we're watching the blood sugar come up and come down, but we're also looking at the insulin, because I could take that test today and use 3 or 4 times the insulin that maybe Sophia would use to get same levels of blood sugar. So this can be pretty powerful, and yet I think using just the HOMA-IR with fasting blood glucose and fasting insulin is almost as effective for just choosing your interventions. And it's a lot easier to talk your doctor into pulling for you. And frankly, who really wants to go in and drink that sugary drink?
You're not going to have to feel how you feel. Yeah, and that's another thing for women with PCOS is we see more frequent migraines, we see more blood sugar crashing, we see difficulties with sleep, with cravings. And so drinking essentially an entire Coca-Cola in one gulp, I mean, that's really like what the amount of sugar is in this drink. if you were to drink a whole can of Coca-Cola in one gulp, your blood sugar would do wild things. And
Yeah,
for a lot of women, I mean, I see this. The worst thing that I see is nausea and migraines from this. Like, do you really want to put someone through that? Migraines are debilitating. Like, you're the rest of the day, maybe even 2 days, you have to like lay in your room with a wastebasket in your bed and a cold compress on your eyes. That just sounds awful, especially when it's not giving us really an amount of information that we can't get in a more comfortable way.
Right. It's super important. So I would say fasting glucose, fasting insulin. Again, we talked a little bit about vitamin D and TSH. I want to see TSH between 1.0 and 2.5 at the very top end. And if there's any variance above or below that, I for sure want to look at a comprehensive thyroid panel. If you have had recurrent miscarriages already, you've had pregnancy losses, or you already know that you struggle with hypothyroidism or hyperthyroidism or Hashimoto's, I would highly recommend in your pre-pregnancy workup that you get a very thorough thyroid panel, and we optimize health there as best that we can prior to pregnancy. What would you throw into that? I want a comprehensive thyroid panel.
I would say that I would want to put antibodies in there for sure. I would want to see your anti-thyroid peroxidase, and I would want to see, oh my gosh, what's the name of the other one? Thyroglobulin, sorry. Mm-hmm. Yeah, I would want to see your thyroglobulin and your thyroid peroxidase.
So usually that'll say anti-TPO. Mm-hmm.
Yeah, or anti-TG is another one. And what that is showing me, so those are not actual thyroid labs. Those are immune system labs. Though that's not talking about the function of your thyroid. It's talking about how your immune system is reacting to your thyroid. And that is something that is really important, because when your immune system is going kooky dukes, it can really impact your brain, your thyroid, obviously, and your ability to get pregnant, your ability to stay pregnant. When we see those elevated immune markers, we also see higher rates of pregnancy loss, and that is very important to note. So that's one that I'd like to look at. And it's treatable. Your doctor might not think so, but it is.
When we're looking at thyroid labs, TSH is actually something that your brain makes, okay? And it tells your thyroid, make thyroid hormone. So TSH is thyroid stimulating hormone from your brain to your thyroid. Then your thyroid, which is this little butterfly-shaped organ at the front of your throat, kind of, it's hanging out in the middle between like your clavicles and your chin. This makes thyroid hormone, and it makes mostly what we call T4, which has 4 iodine molecules on it. This is an inactive thyroid hormone. This floats around your bloodstream, and then your liver has the main job of turning T4 into T3. So it strips off one of those iodines. And this, again, it's like removing the Play-Doh around the key. It turns it into this more active hormone, and then that can float around your body and do what the thyroid hormone does. And there are thyroid hormone receptors on almost every piece of tissue in your body. And a lot of people like to call the thyroid like the thermostat. It's basically a huge piece of your metabolic burn. When you have PCOS, you've likely walked into the doctor's office and said, I want to get pregnant, or I want to help my acne. And no matter what you've said, your doctor may have brought up your weight. If you have some underlying thyroid issue, it's going to be difficult to lose weight, to check off whatever boxes they're giving you, to reach whatever treatment parameter you're looking for, whether that's starting with reproductive treatments like taking letrozole or moving on to IUI or IVF. Oftentimes, a lot of that conversation is centered around weight. This is incredibly important to make sure that we don't have a thyroid issue slowing down or just another obstacle in the way of achieving weight loss or achieving a healthy weight to want to go into pregnancy. Sophia and I are very weight neutral in our approach on interventions. we see weight very often as a symptom of the hormonal problems, but behavior and lifestyle choices impact that. So does your thyroid. So we want to make sure that we're setting you up as you're implementing all these behavior changes, dietary changes, activity level changes, supplemental changes, all these different supports that we put around you. We want to make sure that we're not doing it for naught because your thyroid's just having a really hard time or your liver is struggling and it's part of the process turning T4 into T3. So looking at comprehensive thyroid labs can be very helpful. I think that it should be essential whether you have PCOS or not in a preconception workup. Would you agree with that, Sophia?
Definitely. I'd like to see it as a part of everybody's workup because having low thyroid, having thyroid issues, having subclinical low thyroid. So let's say that maybe it's not like so low that you qualify for medication in sort of a classical sense. It can really impact pregnancy outcomes and it can impact your ability to get pregnant. So that's just something that makes good sense to look at. And again, your doctor may not understand treatments for these things. So it could just be like, I don't really want to look at those things because it might make your doctor feel insecure that maybe they don't know about this. It might make your doctor uncomfortable because they don't want to step into a realm of looking at things that they don't understand. And they don't want to take on the risk of treating something without being super, super confident in how to do it. And it may just be tough. And we're going to sort of end this conversation today with how to communicate to your doctors about these labs too. We're going to give you a little lesson in confrontation. But yeah, that's part of why they're not maybe on like their standard panel, but they're still important to look at.
And in the context of PCOS, if you have insulin resistance, you likely have a higher TSH than we want for preconception. So if you have insulin resistance, you're more likely to have a TSH above 2.5. It's kind of a chicken and egg situation. If you have a TSH above 2.5, your insulin resistance is worse. So they kind of feed each other in a negative way. And so likely as we're treating one, we will see improvement in the other. Will it be enough improvement? Not always. So I just recently had a client who her TSH was like 3.7. In very like normal primary care or obstetrics care, a doctor might look at that and go, it's not that much of a problem. Frankly, it depends on how much exposure your OB might have. Some OBs are like, yeah, we need this under 2.5. But your primary will look at that and go, you don't need medication. As soon as you say, we're trying to get pregnant, we've been struggling to get pregnant, I've had a pregnancy loss, they might look at that a little more closely because it's very clear even in normal lab, like if you go get a Quest lab, they give you the normal range for TSH and then there's first trimester, second trimester, third trimester lab ranges. And those mirror what Sophia and I are always trying to get you to even before you get into pregnancy. So again, for TSH, we're looking at like 1.0 to 2.5 as a more optimal range. If we can get it even tighter, like 1.0 to 2.0, that's where I'm most comfortable. And stress is a huge piece of the intervention side of improving your TSH levels. So vitamin D we talked about, I said it really briefly, but just to give you some solid figures, we're looking at, I would say most optimally between 50 and 80 or 60 and 80 for levels. If you are an international listener, the numbers are a little bit different. In many of the labs where we like give a US metric and then there's an international metric, the numbers like they won't even compare. So you wouldn't hear it and think like, oh, I'm doing okay then. But specifically for the vitamin D lab, what we're looking at in America, we multiply that by 2.5. So if we want to see 50 in America, we want to see 125 anywhere else in the world. If we want to see it up to 80, we want to see it between like 125 and almost 200. So make sure that specifically for vitamin D that we're looking at the units. Let me pull the international unit up for you. We're looking at micronutrients. In conventional medicine, you'll typically see a range of 30 to 100 nanograms per milliliter. In fertility, my slide says 50 to 90, but I typically like to see it 50 to 80 or 60 to 80 nanograms per milliliter. Okay, so to convert nanograms per milliliter to nanomole per liter, which is what the rest of the world uses, like I said, you multiply it by 2 and 2.5. So we're looking at like 125 nanomole per liter to 200 nanomole per liter as like a more optimal range for international listeners. So when we're looking at vitamin D and you see those levels being low, this is critical for you to address as early as you can in your preconception and fertility journey. This is something I don't know why it's so hard to get from a doctor, but for some reason, this lab is like asking for them to like shit gold. I just don't understand. It's like they won't do it a lot of times.
I think it's because it costs extra. I think because in countries with socialized healthcare, it's all about keeping the cost as low as possible because it's right. Taxes go into a pot, and then the pot is what pays for healthcare. And so the less you take out of the pot, the more there is for other things. And in countries like America, where it's not socialized, we have medical insurance, which is sort of like our version of socialization, and it is often not covered by insurance. And so then you either they'll have to sort of battle with the insurance company to prove why this particular lab was drawn in order to get it covered, or it's going to have to be an out-of-pocket expense for the patient. And doctors, I think, are told a lot of times to not do those kinds of things, like don't do something that's going to cost this patient any extra.
Especially if they're on the hook, like if the patient doesn't pay.
Yeah, we've had doctors on the show talk about how they're like constantly being drilled on like keep costs low, keep costs low, keep costs low.
Yeah.
I think that's my interpretation of it. I don't know. And you know what? If you are a listener and you work in a lab or you know something about this, and maybe the process to check vitamin D is like more expensive, whether there's like a substrate they have to mix with the blood in order to look, or it's a more labor intensive test that costs the technician more time. We would love to know if you have an answer for us on that, because you work in this industry. We'd love to hear about it.
So vitamin D, critical. TSH, we talked about. Let's move on to these sex hormones. So when we're talking about sex hormones, typically we're talking about estrogen, testosterone, progesterone. Once you're pregnant, these things become even more important. So when we're treating somebody with PCOS, your doctor may have pulled testosterone, and that would typically be a total testosterone. When I pull labs, I look at total testosterone and free testosterone. I will also pull what we were talking about earlier, sex hormone binding globulin. Total testosterone is the amount of bound and unbound testosterone in your blood. Some of it's connected to sex hormone binding globulin and some of it isn't. The stuff that isn't is the unbound stuff, the free stuff. It's free to go roam around the body and do what it wants to do. This is going to be the most impactful testosterone. So you can have like very normal testosterone levels and have super high levels of free testosterone and really struggle with symptoms and an issue with ovulation and poor egg quality. So we want to look at these three kind of together. I want to look at, are you just pumping out so much testosterone? Do we have like a high pulsing of testosterone from the ovaries? Are you making a normal amount? You're just not being able to bind it up and turn it off. And so we have higher levels of free testosterone. Or are those levels okay and your sex hormone binding globulin's doing kind of okay? Then we might focus on a different avenue of treatment and zoom in closer on the androgen that your adrenal glands make, which is the DHEAS. So just to give you some rough figures, I oftentimes see testosterone between like 40 and 120 for clients. As soon as we start clicking up above 80, I can start seeing issues. Sometimes if I see testosterone really low, first of all, it makes me wonder, is this really PCOS? But that can also impact your fertility. So we kind of have this like Goldilocks level of testosterone we're trying to get so that you can have a healthy libido, so that there is some progression of follicle development that needs a little bit of testosterone, but you don't want too little, you don't want too much. So kind of within this 40 to 80 range, anywhere in there can be okay. But then I'm also looking at your free testosterone and what ratio of that. I want to see free testosterone like under 4.5 or 5. When I'm looking at sex hormone binding globulin, again, remember this number, kind of the higher the better. I want to see that well above 40 to 60. So I want to see that if I can closer to 80 or 100. I would be happy to see. In this 40 to 60 or under range, I typically start seeing problems. And I mention this because it's really common to see it really low. I looked at labs last week of somebody who had like a 12, which is very low sex hormone binding globulin, and can really throw, something in the way of your testosterone metabolism, getting it turned off and out of your body and impacting ovulation. So let's say testosterone, free testosterone, sex hormone binding globulin, we see a picture of something that's like fairly okay, or maybe even really high. I still want to look at your adrenal gland and say, what is your adrenal gland doing in terms of making a hormone called DHEA-S? You'll also see sometimes ordered just DHEA. This isn't sulfated. We typically look at the DHEA-S in the PCOS world and are looking at, is this level moderate? DHEA-S is an interesting one because your body makes more of it to protect your brain from cortisol. And cortisol is another hormone that your adrenal gland makes. Your adrenal gland is kind of like this fight or flight and stress response organ. It's pretty far away from your sex organs compared to some other organs like your bladder, but it really can impact your sex hormones and how you're ovulating with PCOS. If you are somebody who is under heavy loads of stress, no matter if they're physical, emotional, financial, relational, your body could be pumping out so much DHEAS that we're impacting your body's ability to ovulate. So looking at this level can sometimes paint a picture or help explain why is ovulation or why is egg quality the way that it is when we don't see an issue with testosterone levels. So I like to order DHEAS and an AM cortisol and look at them together to see like, how does this person wake up and deal with the stress of the day, and look at DHEAS kind of like a surrogate marker of somebody's overall levels of stress and how their adrenals are responding to that stress.
So before we get into more about DHEA sulfate, let's hear from our sponsor. We're taking a quick break from this episode to ask a very important question. Caitlin, if you have someone come to you trying to grow their family, trying to make some babies, and they're like, okay, I'm willing to take a supplement, just maybe not a counter full of them, what would be your number one pick?
A prenatal, but not just any prenatal. I would recommend Fullwell Fertility.
Okay, so why that one specifically?
Oh, that's a really good question. So since this prenatal's come to market, first of all, it's the only prenatal I've taken in pregnancy. It has 4,000 IUs of vitamin D. It has way more magnesium, iodine, choline than a lot of other prenatals. And it's really thoughtfully formulated to not just have amounts that are important in fertility and pregnancy and postpartum, but the types and forms of these vitamins and minerals that are going to be easily absorbed and utilized within your body.
You will truly not find anything better on the market, not only when it comes to formulation, but when it comes to testing, like making sure not only is it safe and not contaminated, which has been a bit of an issue in the prenatal market in past years, but making sure that every batch actually has what the bottle says it has in it. So this makes sure that they didn't just slap a nutrition label on saying, hey, you're getting 4,000 IUs of vitamin D, but the formulation company actually goes through and makes sure every batch has the exact amounts of these nutrients that they say they have. I have not seen anyone else in the industry take their standard that high, and that is why we love Fullwell.
Man, it's really impressive. The creator who we've had on the podcast, I just have a total crush on her because it not just meets industry standards. I feel like she's a trailblazer, setting new standards and changing the landscape of the market.
So head over to fullwellfertility.com and enter code FFF10 for a 10% discount on their prenatal, the fish oil, or their men's prenatal. And now back to our episode. So DHEAS and cortisol. Cortisol has wide levels throughout the day. In the morning, you have this kind of awakening response where it starts low, it goes high, and then it kind of gently goes down a waterfall throughout the morning and then even slower incline into the afternoon and evening. DHEAS is more consistent throughout the day. So getting an AM cortisol is helpful. And if you're going in for fasting labs anyway, that's an easy thing to ask for. When we're looking at DHEAS, we're typically looking at lab values when you get your printout from the lab or from the doctor's office that are not gender specific and they're typically not age specific. And this can be difficult to interpret with that in mind. So by and large, the big picture I want to paint for somebody with PCOS is that we're looking for a lab value at or under 200. I don't want to see this floating in the 300 or 400s, even though that might be a normal level per the lab printout you have. That's not for a 20 to 30-year-old woman. That's for the general population. If you see really high DHEAS levels, no matter what we see in your cortisol, we have to approach stress. And to the point where you may need to make major life changes to address your stress because no amount of just throwing adaptogenic support or doing deep breathing right before bed is going to impact this level as much as we need.
Breathe before your bread too. Breathe it in. Smell that fresh bread.
Breathe it in. Sophia just pulled
I just made a loaf of bread, everybody.
Out of oven. Yeah, I want to breathe your bread. Okay, so that's kind of the androgen picture. You might have somebody that says, let's pull DHT. DHT is a really potent and powerful androgen, and it's a really kind of poor lab marker to evaluate from your blood because most testosterone gets turned into DHT inside of a cell. And so it's not then hopping back out of the cell and floating around in quantities that are really helpful to draw in blood and then interpret. Typically, if I see a lot of facial hair, hair loss, acne, I'm looking we need to annihilate testosterone so that it doesn't turn into DHT anyway. So save your money and save your advocating for yourself. I used to ask people to ask for DHT. I don't anymore. And I hardly ever test for it. So other sex hormones that you might think about and maybe are more obvious to you are estrogen and progesterone. And again, earlier in the episode, we talked a little bit about how in a PCOS ovary, we make testosterone and do it at the expense of estrogen production. I kind of see two very drastically different symptom effects and cervical fluid effects and can usually pretty accurately guess who is struggling with estrogen production or not, just based on, are you producing a lot of cervical fluid? Is it getting to that egg white texture? Is it happening multiple times in your cycle or for more than 1 or 2 days? If you're somebody that like has cervical mucus for like 1 day and then you ovulate and we have a short luteal phase, I can typically guess that we're having an issue with making enough estrogen. And so I like to look at estrogen in comparison with testosterone to a degree, but your symptoms can tell Sophia and I a lot about that without having to dig super deep into estrogen. So if we're not doing something like a urine analysis, like a Dutch profile, which is never where I start with somebody with PCOS anyway, we're typically just drawing a lab called estradiol. And typically we're looking at this on day 3 of your cycle. So as we start moving into talking about like estrogen, progesterone, LH, FSH, these hormones, it's helpful to know where you are in your cycle for us to be able to draw conclusions about it and help choose interventions based off of it. So you might be listening to this and say, that's great. I'm on day 200 of my cycle. Like, when should I draw it? Should I go to the doctor and get some sort of birth control or progesterone prescription so that I can stimulate a bleed and we can draw labs? In a scenario like that, I like to just draw blind, meaning we draw now. We're likely not going to draw progesterone because we're going to assume you haven't ovulated, and we're going to look at estrogen, LH, and FSH, and we're going to look at it in the context of you haven't ovulated. So what's your body doing in this, like, I haven't ovulated state? Is your body trying to ovulate? Like, what do these labs tell us? For everyone else who might be cycling, even if you're having a long cycle, I like to draw day 3 labs. So when we say day 3 labs, we're talking about the 3rd day of an active bleed in your menstrual cycle. So like day 1 is not spotting, I saw a little red or brown blood on toilet paper. It's like I had to use a tampon, a period cup, a pad. I had to do something because the flow was enough. It was going to impact my clothes, right? So day 3 of that's day 3 of your cycle. I've had some people where they're like, I spotted for 4 or 5 days and it was like kind of in between. It's not an active flow, but it felt like more spotting. If you draw, then we're likely going to see that it wasn't even really a true period. It was just spotting. And we'll see things in those lab values that give us hints at that. But typically a day 3 lab, we're looking at kind of a lower to moderate level of estrogen that we're looking for. And we're looking for certain ratios of these other hormones called LH and FSH. We typically don't want to run a progesterone on day 3 because your body makes progesterone after you ovulate. And once your body realizes you're not pregnant, you stop making progesterone, which stimulates your period. So if we pull progesterone on day 3, it's going to be close to 0. It's not going to tell us hardly anything. Estrogen, however, and LH and FSH have really important roles at the beginning of your cycle to make ovulation happen. Estrogen starts kind of low, and as it climbs, it pulls luteinizing hormone up, and we see ovulation happen. Follicle stimulating hormone is rather consistent, but a little bit higher at the beginning of your cycle, typically, and then drops off a little bit. In somebody with PCOS, we're not so much looking at is LH within range or is FSH within range at day 3. We're looking at a ratio of those two. So typically on day 3 of your cycle, FSH and LH are going to be close to equal. If anything, we want to see FSH a little bit higher. And these will usually be in like mid-level single digits, like 5, 6, 7. Okay, somewhere in there. If you have really high FSH, like 14 or 16 at the beginning of your cycle, that tells us something. If you have FSH at like 5, but your LH is like 20, that also tells us something. So optimally, we want to see these levels close to equal, if anything, FSH a little higher within the single digits on day 3 of your cycle. Estrogen, what would you say, like what are you looking for estrogen to be towards the beginning of your cycle, Sophia, if we're looking at that?
So on a day 3, geez, I would honestly need to pull a lab value to look at it because off the top of my head, I don't know what I would want to see the estrogen being.
So, and it honestly may not be as important, not in a PCOS case. Like maybe it is, maybe it's not. But so estrogen, when it's reported on your lab report, you're going to see pre-ovulatory, you're going to see ovulation, you're going to see luteal phase, and you're going to see pregnancy values typically, because estrogen varies very widely throughout the cycle. So I would say more often than not, I see estrogen levels in the like high double digits early on, like day 3 of your cycle. So that could be like in the 70s, 80s, maybe 90s. If it's over like 150 that early in your cycle, something's going on that shouldn't be. If it's like 12 or 15 or 20, it's not typically high enough, because estrogen kind of drives that like setting up beginning stages, building blocks of this endometrial lining again. And we want it to be at a certain point.
That's part
once
of why
we
you
ovulate.
start to feel better around day 3.
Exactly.
That's why, like a day or two before you start your period, like let's say you don't really, you're new to tracking your cycle. You don't really know when you ovulated. You're not sure when you're going to expect your period. And you're just like, man, life sucks. I'm feeling sad. I feel gross. All things are wrong in life. I'm really grouchy. My boobs hurt. And then you start your period and you're like, oh, that's what that was. And that's why also for like the first day of your period is generally where we see people have the most cramps or the most like headache or whatever they've got going on. Day 2, things are a little better. Day 3, we're out of the woods. That's usually where things start to feel a lot better. And that's because that's where we start seeing all of these other hormones start to pulse. So you kind of come up out of the ditch and feel better. There's a hilarious quote from The Office that we should use for this, where Dwight talks about like, when women get their periods, they cry, they're sad because they didn't get pregnant. And then they feel happy again when their period is like coming, or where they start to ovulate again because they get another chance. I'm butchering this quote. Something like that. It's funny. I'm telling the worst joke. This is me being my father right here. Explaining someone else's joke in a way that's like super not funny and also butchering it. Anyway.
So it's interesting.
Sort of
when you look at estrogen, like a lab value of estrogen in like on a day 3 lab value. Remember how I said there was those different categories it's going to report, kind of follicular, or they'll call it pre-ovulatory. That's when the follicle's getting ready to ovulate. Then ovulation, then luteal phase, and then pregnancy. There is this huge swing that happens in that first category, that pre-ovulatory or follicular phase, where it's like, it's really normal for your estrogen to be almost 0, but can also go up to like 300 because it needs to stimulate ovulation. So you'll see this really wide range, and yet we want like not too low, but we don't want that high part right at day 3. We don't want you ovulating like 7 days into your cycle. That follicle is not going to be ready. And so having it be like kind of in the high double digits, low triple digits, like 120 or something, but not super high on day 3 is helpful and kind of imperative for really healthy cycles. If we're doing just a blind draw where you haven't had a cycle in a really long time, seeing estrogen in that time point can be really helpful, because like, let's say in that time point, we see low FSH, but high LH, we see like in the dumps estrogen. That's telling me your body's making a whole lot of testosterone and it's not making the estrogen to pull the eggs along and get ready for ovulation. So I really think, honestly, if you have PCOS, you need somebody that understands these labs to help you interpret them to make sense of what to do at some point. Like, work on the dietary interventions, work on all the other things that Sophia and I teach you, and then enlist someone that really understands these labs if you're still struggling to get pregnant, because they can tell us things and help us prioritize interventions. The other main like female hormone that we're looking at is progesterone. Progesterone is that hormone that shows up after ovulation, and we need it to be like super high in pregnancy to keep pregnancy happening. When Sophia was talking a little bit earlier about progesterone resistance or the combination of high insulin levels and low progesterone production, like the corpus luteum that makes the progesterone and its inability when there's high levels of insulin, I feel like I'm seeing this so commonly in practice where clients are being told to try letrozole or try Clomid, and they can ovulate, but they are not making the progesterone that they need, or their body is being resistant to the progesterone. And so they have higher needs of it to kind of like bombard the body with it so that they can hold a pregnancy or even just allow implantation to happen. And I'm just not seeing it common enough protocol where when somebody is being provided letrozole or Clomid, that they're just off the gate providing them with progesterone too. And I'm of the opinion now that it's more important than even what I thought 2 or 3 years ago for women with PCOS to get extra progesterone support. Not everybody needs it,
very
but it can
important.
be so helpful. And so why not?
It can be so helpful, and the risks are pretty low. The risks are pretty low to using exogenous progesterone. There are risks. I would say the most drastic of such being that a missed miscarriage, meaning that the pregnancy has no longer progressed, but your body has not recognized that because you're having this exogenous progesterone that's keeping you from shedding your endometrial lining. So
a missed miscarriage. The interesting thing there is that like progesterone's not going to stop a miscarriage that's due to a genetic, like this baby wasn't going to make it, period. Like there was some sort of genetic mutation or too many chromosomes or not enough or just something going on. It may slow down kind of like the blood loss. And that's why I hear a lot of doctors say this isn't a great idea. But it can help a pregnancy that low progesterone might be the cause of a pregnancy loss. And more often what I see is people not being told how to take the progesterone and the progesterone prolonging the luteal phase and the next cycle not starting even though pregnancy hasn't happened. Like I remember having a client that was on like day 18 of progesterone and having negative pregnancy tests. And I'm like, well, you're having negative pregnancy tests because you're not pregnant. So you need to stop the progesterone now and give your body a chance to start the next cycle. So more often I have seen that happen than but if I think it's one of those risk assessments, I would rather have a little bit more of an issue with missing a miscarriage than having a miscarriage that would happen if I wasn't taking the medicine.
Yes. I would rather have, and what Caitlin means there is like, we think it's in our medical opinion and personal opinion, if you're going to get pregnant, we would rather have that pregnancy have every chance of making it. And then if it doesn't make it for reasons that have nothing to do with progesterone, you maybe would have a bit of a more complicated road than having pregnancies that had the chance at being viable, not making it because you didn't use the progesterone. Because if you're using the progesterone and you have a miscarriage anyway, or maybe it depends on how you define miscarriage, because sometimes it's that the pregnancy stops progressing, the baby isn't growing, there's really nothing in the gestational sac, there's a whole lot of nothing happening there. The progesterone can hold your body back from expelling that fetal tissue and restarting your cycle. And that's a better risk, quote unquote. We'd rather have, although that is traumatic and sad, that pregnancy was never going to be able to make it, even if you weren't using progesterone. Using the progesterone gave it as much of a chance as it could possibly have had.
It is interesting, though, that I see, and I've heard doctors say progesterone won't stop a miscarriage from happening. And then that's their argument to not give it. And it's like, okay, either way,
sometimes,
if the client's saying,
that's true in some cases.
So progesterone is something that you will be offered if a doctor says they're going to pull it. They're going to say, I want to pull it on day 21. Do you want to explain why that happens, Sophia?
I would love to, Caitlin. So progesterone on day 21, this is based off of this 28-day cycle. So when you ovulate, where the spot on your ovary was that had the egg now turns into a brand new organ called the corpus luteum, which begins secreting progesterone. This is not like a bomb going off. This is not like a switch flipping in your ovary. It's not like you go from little progesterone, now the egg pops out and it's like fireworks spraying a fire hose of progesterone into your bloodstream. It's not like that at all. It's more like a preheating oven where now you've pressed the start button on the oven when you ovulate, and it's going to slowly bring it up to temperature to bake your baby. And if the baby isn't in there, the oven will shut off and restart its baking cycle. But this 21-day progesterone is based off the premise that you're probably ovulating around day 14. Because most women ovulate somewhere between day 10 and day 20, like somewhere in there. I would say between day 10 and day 16, there's usually, most women, like 85% of women who are still ovulating, will ovulate in that timeline. So we then would draw blood on the 21st day of your cycle to see what your progesterone is doing, to see if you ovulated, if you're making enough progesterone to sustain a pregnancy. So that's when we would test that, because again, it's like a warming crockpot, preheated oven kind of thing. You're not just going to immediately have a ton of progesterone. It takes days for your progesterone to reach a high enough level for us to say like, okay, ovulation definitely happened, and your body is now responding by doing all the things that your body does after you ovulated. This can be great for people that have regular cycles, but or just not even regular cycles. Okay, this is great for people that have a 28-day cycle or a 30-day cycle or a 24-day cycle, somewhere in there. You can have a regular cycle, but it's just not that timeline, and the 21-day wouldn't be that great. Like you can have a 40-day cycle, and the 21-day progesterone is not going to be that great for you. So if you have listened to this podcast for all of 5 minutes, you will know that Caitlin and I say it is a must to track your ovulation. You must know when you're ovulating. And we want to draw your labs 7 days after ovulation. So sister, if you're ovulating on day 10, that would be a day 17 draw. 17. If you're ovulating on day 40, that would be did I say 17? Day 17 draw. If you're ovulating on day 40, it would be a day 47 draw. If you're ovulating on day 100, you'd want to see those labs on day 107. Okay, we're making no assumptions as to the length of your cycle. If you're ovulating on day 100, sister, we want you ovulating more frequently than that for your own health and for your TTC journey. But even so, any ovulation is a chance at pregnancy. Let's look at that 7-day post-ovulation progesterone, because that's what's going to show us. That's sort of the peak, right? That's sort of what we medically recognize as like, this is probably as high as it's going to get if you are not pregnant. If you are pregnant, it's going to continue to rise. But if you're not pregnant, this is as high as it's going to get. And so we're going to see it at its best. That's the theory.
Absolutely. Your doctor will likely be willing to pull what they call a 21-day progesterone. You're just going to need to know, I need to have some cycle awareness, need to know when I'm ovulating, and then go 7 days after that. And if you are in like my Find Fertility course, all the time I look at people's charts and they're like, hey, this is the day I think I ovulated. What do you think? And when should I go see the doctor? I think that can be really helpful for somebody with PCOS, especially if you're kind of in the infancy of learning how to track your own cycle and track ovulation. With that being said,
and you can call it a day 21 progesterone. Like if your doctor says, look, I want to check your day 21 progesterone, but you know that you don't ovulate till day 30, you don't just it's fine. Just go in on day 37 and say it's a day 21 progesterone. It's all good. You don't need, your doctor's not in your underpants checking when the blood comes. Okay. You're the only one that has that little tidbit of information. Your doctor's not checking your cervical mucus. So you can check your cervical mucus. You can check your basal body temperature, and you can schedule an appointment 7 days after your ovulation and let them call it a day 21 progesterone. I don't care what they call it. We just want the information that we need.
And what are we looking for? What value are we hoping to see?
I like to see higher than 15, but the data says best outcomes over 25. But remember, sisters, like we said at the beginning of this episode, we are treating the woman, not the lab. Okay? We're treating the woman, not the lab value, not the blood test. So it is 100% possible to have a healthy pregnancy, a healthy baby, healthy ovaries with a 15 or 12 even progesterone on your day 21 quote unquote draw. Totally fine. Mm-hmm. Clinically, we see the best outcomes when it's over 25. But that doesn't mean you're doomed if you are not at 25. It doesn't mean there's anything wrong. We have to look at that in the context of the overall picture of your reproductive health. So I know I'm harping on progesterone all the live long day over here, but just know you don't live or die by this number. This is just one piece of a greater picture. So if I had to pick what is best over 25, what is something where I start getting concerned there might be a problem? Below 15.
Under 15. Mm-hmm. I just had somebody that is pregnant, had a 12, and their doctor was like hemming and hawing about giving progesterone. And I was like, what's the problem? This is low, period. It's not what we want. Retest it. Great. But like, let's get some more support on the board. Like, where's the negative? Like, it just blows my mind. So anyway, this one is, I would say, like walking in and asking for vitamin D versus progesterone. For some reason, progesterone seems to be like the easier one to get, even though vitamin D has just as much relevance in my mind. But just remember, early in your cycle, you're not going to have high levels of progesterone. You're asking for progesterone. 17-hydroxyprogesterone is a different lab. And that one you're going to see higher levels of. So if the doctor accidentally pulls it, you'll be like, oh, my progesterone looks great. It's 30. Well, you're not looking at progesterone. You're looking at 17-OH progesterone, 17-hydroxyprogesterone. That is actually a lab we use at diagnosis to rule out other reasons why you might have PCOS. So you may see that in your lab work, but that's not the one we're looking at to make sure ovulation is as optimal as we need it to be. Okay, so we've talked about most of the sex hormones. We talked about the thyroid and the liver. The other two things that we want to think about when we're going into pregnancy, or things that could affect if you can get pregnant, are things like inflammation and nutrient deficiencies. So inflammation, honestly, most people with PCOS have inflammation.
Most people with consciousness in a body have inflammation. Yeah, but no, sisters with PCOS, definitely, they have a higher level. They do have a higher level. It is considered a more inflammatory condition.
And that can impact implantation. And so the easiest lab value to advocate for is HS-CRP. It's a highly sensitive C-reactive protein. And this has great implications for somebody with PCOS because it is a marker that, looking at it, gives us an idea of cardiovascular risk, but it also is just a pretty good surrogate marker of inflammation, period. It isn't really diagnostic as to where the inflammation's coming from, but it tells us it's there. And oftentimes with PCOS, without the presence of another autoimmune condition, I zero in on insulin as being the primary pusher of this higher level of inflammation. As we deal with insulin resistance, this typically comes down. And so asking for an HS-CRP can be helpful. You can go off of the values that are on kind of the lab reference ranges to see if it's an issue. If your doctor is willing, you can also look at homocysteine and interleukin 6. These are also inflammatory markers that I like to look at if I could just like wave a magic wand and look at anything I want to look at. And then the other things that we want to talk about preconception and related to fertility are things like you need to go into pregnancy with the highest level of a healthy kind of like iron balance within your body. Having low levels of iron going into pregnancy is not going to set you up for feeling great. It's not going to be great as your blood supply expands. So typically when we're looking at that, you can get some information from your CBC because that gives you things like total iron binding capacity, yada, yada. But I also in PCOS like to look at ferritin. And since we're talking about nutrient deficiencies and inflammation, kind of in the same segment of this episode, if you have really low levels of ferritin, which is your storage capacity for iron, that oftentimes correlates with inflammation. And so we can look at things like HSCRP, but if I also see your ferritin levels are low, so your storage iron versus like what is floating around in your blood supply for ready use all the time, that's something that I consider, and we will maybe add in something else for inflammation like curcumin or turmeric as we're trying to replete iron levels.
And that's something particularly to look at if your issue in PCOS is you aren't cycling regularly, but then when you do get your period, it's from hell. And you are just having, it's 3 weeks of soaking pads and tampons. That can be indicative that your iron levels are not doing so good. That is... Sometimes in PCOS, we see women with great iron levels because they're having like 2 periods a year and they're holding on to all their iron. And that's exactly. But other times we see it go way in the opposite direction because when they do get their period, it is like that scene in The Shining when those 2 doors open. It is just so much blood and they just feel like absolute garbage and they're just burning through pads and tampons and menstrual cups. And I just feel so sad because like looking back at my life, there was a girl that was in a Girl Scout troop that would meet in the same park as my Girl Scout troop. And I remember she had her period all over her butt. And it was like before the rest of us got periods really. And we were like, oh my God. And nobody wanted to talk to her about it. And then I've known her like into adulthood and she absolutely had hirsutism. She had like the weight loss. She had hair loss, skin tags, overweight. And I'm like, I wish that I could just go back in time and like embrace this sweet soul and be like, this is not your fault. Like there's something going on and it's very, very treatable. But anyway, I just think of her because it was like so much, she like huge amount of blood and just so
that happened to me
for her.
7th grade. It was terrible. In choir class. It's the worst.
Definitely happened to me. It's happened to me when I was visiting with my sister's husband's family who has all boys and I'm like bled all in their guest bed. It was the worst. It's happening. I have uterine fibroids. And so I also have these like really heavy.
You have other
periods.
reasons to have horrendous periods.
I don't have PCOS, but I could make your hair curl with stories with gross period stories. But anyway, since we're talking about PCOS labs today, I just think about that sweet girl and how sad that must have been and scary and embarrassing for her. Anyway, iron. Yeah. Okay. So other nutrients we want to look at. B vitamins are a big one.
Yes, especially B12, because many of us come into this time of our life coming off of birth control or we've been prescribed metformin, and both of those kind of increase your need for B12, so you're running through your supplies more quickly. And B12, if you're somebody who does not like to eat meat and you've been on these medicines, we likely have some work to do to get you into a safe place in terms of having high enough levels that are going to support pregnancy. And this is like critical very early pregnancy, like, as the brain
before
and
you
the
even
spinal
know you're
cord
pregnant kind of stuff.
Yes. So micronutrients, I like to look at B12. Do you regularly test any other B vitamins pre-conception?
Sometimes I look at folate.
I mostly just stick to vitamin D and B12.
Folate, B12, those are pretty much the only ones.
Yeah. So we want to talk a little bit about how to advocate for these labs.
Before we do that, we're going to take a quick break for our sponsors, but when we come back, we are going to talk about how to have these conversations with your doctor, how to advocate for yourself, how to partner with your doctor. And it's not you versus them. It's both of you working together to get you that healthy baby. We're going to give you all of our secrets when we get back. And plus, we'll do our Yeah Girls. Hold on just a second. I know you're loving this episode. Anybody would. But we want to talk to you about our sponsor, the Prenatal Nutrition Library.
We love the Prenatal Nutrition Library. It is like Google in your pocket for pregnancy nutrition questions.
Yeah, but it doesn't have any of the weird stuff in it, like some blogger who has a personal vendetta against shrimp. It is run by a registered dietitian, so you know the information you're getting is accurate.
And if you're feeling like, shrimp in your first trimester and you don't know what to eat, and you don't know how to manage the fatigue and nausea you have, but you know you've got this little blueberry-sized something growing in your belly that needs nutrients, if you join the annual membership for the Prenatal Nutrition Library, there is a resource that has meal guides and actual recipes thought through for both those symptoms and the nutrient needs by week in the trimesters to make sure that you're outfitted to have the healthiest pregnancy.
We are so happy to be offering this to you. And in fact, we have a discount code. FFF20 will get you 20% off either the monthly or the annual membership.
So head over to the Prenatal Nutrition Library. And now back to our episode.
Now that we're back, let's take this time to help you feel really equipped in how to broach the subject with your medical provider, be it a doctor, a nurse practitioner, a physician's assistant. Because I know all of you who are listening are like, cool story, Caitlin. I've talked to my doctor about all of this and they gave about 2 craps and told me no. And then that was the end of it. So how can we actually get our providers, our people that are supposed to be our medical allies to hop on board with some of the stuff that they aren't offering?
In a perfect world, they're going to want to help you. And if you're interested in something, they should be interested in it. We don't live in that perfect world. Like, it's just not the way it is. So going in...
No, we certainly don't.
First of all, I think going in knowing that you might have a little bit of an uphill battle, I like to bring my husband with me in conversations like that. I hate that this is the way it is, but typically if there's another human in the room, particularly if they have a penis, the conversation gets taken more seriously. It just...
And big muscles?
Yeah, it just does. And it sucks, but it's true. I've had a lot of experience trying to advocate for myself and my children. And at the end of the day, I've come to say a sentence like this. These lab values will mean something to me. And even if they may not mean something to you, I'd like to respectfully ask that you would order them for me because they may affect certain interventions that I do at home, like what vitamins I might take or what supplements I might take. I'm working with a trained professional and I want to be able to provide this data to them. If that gets met with resistance, because for many of us it will, the next sentence I'll say to them is, well, if we can't come to an agreement on the lab work that we want to pull, I'd like for you to make a note in my chart that I've requested these labs and that you have declined ordering them for me. The 2 times in my life I've had to use a sentence like that, the doctor's just been like, if it's that important to you, fine, I'll draw the labs, but I don't think they're going to tell us anything. So I like to start going in respectfully. I like to bring someone with me if I can, if that will help me feel strong in my advocating for myself. And I like to just explain, this is going to affect things that I'm going to do, because that's the truth of the matter, right? We're going in trying to get comprehensive lab work so that we can make tailored and individualized changes. What would you add to that, Soph?
Mm-hmm. I would add just sort of a shift in your mindset is really the first step to this. Your doctor works for you. They work for you. If you don't go, they don't get paid. And that is the relationship that you have there. Ideally, our doctors would have a sort of collaborative mindset toward us. The school I went to, the doctors that were being trained there, and even me, I'm not a doctor, I'm an RD, not an MD, but we sort of were indoctrinated with this phrase docere, which is Latin for doctor as teacher. And that's what I like to look for in a doctor, is a doctor that wants me to understand, that's going to explain things to me, that's going to collaborate with me, that we're both coming together to get me towards my goal, which is a healthy pregnancy in this circumstance. We're working together towards this. The doctor's bringing in education, expertise, experience, access to things like labs, procedures, medications. I'm bringing in my symptom set, I'm bringing in my body, I'm bringing in the fact that I'm going to be the one that actually has to go and do. They can write every prescription under the sun. If I don't go fill it and take it, it's zero good. They can tell me to change how I eat, how I sleep, how I exercise, whatever. If I don't go and do that, no one makes any progress. So we're both coming together to work together towards our goal. And that's a very important mindset shift. It's not you bowing down at the temple of doctor and, the saintly Lord and doctor comes out and dispenses some life lessons down to you, the peasant, bowing at his feet. That's not the relationship. That's the relationship maybe our grandparents had with their doctors. But that's not a relationship that I want you to perpetuate. That's not the relationship I want you to cultivate. That's not the energy that you need to have walking into that appointment. You walk in as an equal. You are equal with this doctor. They're not your servant that needs to hop to when you snap your fingers. And they're not the boss of you. You're both equal, working together towards your goals. And having that mindset makes it a lot more like if someone who's your equal has a disagreement with you, criticizes something you say, doesn't want to do something, you're much more likely to say, okay, well, let's talk about it. What makes you not want to do that? What are your reasons behind this? Here are my reasons behind it. It makes it much more collaborative than if you were going into like your boss, pitching an idea, your boss shoots it down. You might not have the authority in that meeting to say, well, I think you're wrong and here's why. So go into these appointments with the mindset that you and your doctor are equal. You are equals. So you have the confidence to bring this kind of stuff up and continue the discussion, because your doctor may have a very good reason for not wanting to draw these labs, for not wanting to do certain things. I don't know your medical situation. I don't know what you've been through. Caitlin and I have no freaking clue what your life is. Your doctor will have a lot more personal experience with you. So I'm not going to say your doctor's just being mean in not wanting to draw these things. There could be a good reason. But so if you ask your doctor, okay, you don't want to draw these, what's the reason why? They may have something to say like, well, the fact that you were on such and such medication for this long, I think if we drew these labs today, it really wouldn't show us what we need to see. What I'd like to do is change up this and that, send you on your way for the next 6 weeks, and if nothing has improved, then let's talk about labs. Oh, slam dunk. I mean, Caitlin and I, that is a conversation both Caitlin and I can get behind. We don't feel like that doctor's a bully. We don't feel like that doctor's just being lazy or scared. That's a doctor that has a plan. And because you were just on a medicine, a supplement, you're just coming off a pregnancy, whatever your situation, drawing a bunch of labs at that moment may not be the best choice for you, may start up with some unnecessary interventions, may cause undue stress, when if we just sort of left things alone and checked a little later down the line or whatever, it could be more beneficial. So don't just come in guns a-blazing. Your doctor may have a very good reason, but probably not. What I've seen more often than not is it's just a doctor who is being a wet blanket, being a stick in the mud, doesn't want to come outside of his or her little comfort zone, and doesn't want to have to learn, doesn't want to have to admit that he or she doesn't know how to interpret these labs, that he or she hasn't been trained on how to treat this, that, or the other.
I think they're also pushing against like that Dr. Google thing, right? Like they are seeing lots of patients coming in asking for things and then having no idea how to interpret it or what to do with that information. But even if you aren't working with Sophia and I, if you can advocate for a fasting insulin and a fasting glucose, and we see a high HOMA-IR score, and yet your A1C still doesn't tell you you're pre-diabetic or diabetic, that information can arm you with a lot of motivation to make some behavior changes. And simply getting a fasting insulin sometimes is like asking a doctor to move a mountain. They're just like not willing to do it. And so while in a perfect scenario, they are an advocate, just be okay with the idea of if this conversation doesn't go the way that you want, or they don't have a really good reason for explaining why they want to draw the labs later or don't want to draw the labs at all, that in most circumstances, you have options to see a different doctor and have the conversation over again. Because what Sophia also brought up is that they're working for you.
And you don't have to make them like you. It's not your job to go in there to make a best friend today. That is really, really hard for someone like me, a chronic people pleaser, someone who steps into performance mode any chance I get, who's always trying to like crack the joke, ease the tension. I'm like a salesman, essentially. And that can be really tough when you're sick and you're trying to have someone help you be well, to not be like performing or trying to get it right or trying to get an A+ at doctor's appointment. And that's something that's most of us women really battle against, is like trying to get it right, syndrome. Trying to be their best patient of the day, trying to be good girl syndrome. Yeah, Midwestern good girl syndrome. And it's okay if you ruffle a couple feathers there, being very respectful, but saying, I understand that's your policy, but it's my body and I want to know these results for my own learning.
I think another really simple question you can ask is, will this information hurt me if I know it? Like, for instance, most doctors don't want to pull a vitamin D lab, a simple lab. But if you just pose the question, is there any harm in me knowing this information? Generally, they're just going to say it's an expensive lab. Well, doctor, you don't worry about that because my insurance is going to cover what they'll cover and I'll take care of the rest. So if they say no and they don't have a really great explanation why they're saying no, just simply asking them, hey, what's the harm in me knowing my HOMA-IR score? What's the harm in me knowing my vitamin D lab?
100%. Yeah, just and if they don't have a good reason, then I understand that it costs more, but I'm prepared to pay that. Or that that's not as good. Thank you for trying to make this affordable for me, but I'm ready to spend on this, or I've been saving, or whatever your situation is, that you're prepared to make this work for you. You're prepared to make it work financially. And, because that can also be a piece. And again, that's the doctor kind of infantizing you, being like, oh, well, silly woman, it's called money, honey. It's numbers. I know those are hard for you because you're a girl. It's okay. I'll make sure that it stays in budget for you. And you don't have to follow that. And they also just don't want you coming back and being like, oh my God, why didn't you tell me that this costs $65? Because then they have to deal with that. So just be like, yeah, I know it might not be covered, but I want to do it anyway. I'm ready to pay for this. It's not their decision. Just like Caitlin said, don't you worry about that. That's me.
So I think this might bring up two more questions. What about other options if my doctor says no and I can't find a doctor that will order it? I just had a scenario like this with a freshly pregnant person, and we wanted to get really simple things: vitamin D, TSH, beta HCG, progesterone. The doctor wouldn't pull anything but beta HCG. And so it's like, okay, well, what are we going to do? Very rural patient. There wasn't any labs that I had access to order for her. So her basic option was like, find a home birth midwife that is a little bit more workable in your area, or go to a naturopathic doctor, because usually they'll be more willing to order some of these. Sometimes with a home birth midwife or other certified nurse midwives, they may not have the ability to order some labs in the areas that they're in, but finding an alternative provider in the state of California, you're primary care provider can be a chiropractor or an acupuncturist. While I don't recommend that for everything, I think that they're also a valid route to go in and say, hey, can you help me get these thorough labs that I'm requesting? There's a lot of direct-to-consumer lab options. Like where I live now, there's a place called Any Lab Test Now. You can go in, you just get whatever lab test you want. You just pay out of pocket. They don't run insurance. I think the other question people will ask is, well, if I can't get it through my doctor and I don't want to go into one of these lab places, can I just do those like Everlywell mail order tests? What do you think about that, Soph?
Those are an option. I'm a little concerned about how accurate they are, and I want you to know it's a lot of blood. You're going to have to slice your finger open and milk a lot of blood out of it, and you're probably going to have to cut multiple fingers to get enough blood out before it clots. So keep in mind that is an option. It's a little bit of a different situation because some of them you're like soaking a piece of paper, some of them you're like dripping it into a little vial, and you can do that. I am not sure how much that impacts the efficacy, but it's not a very comfortable situation because it does require a lot of blood. If only Theranos was real and that lady wasn't a fraud.
No kidding.
We could just look at one drop. But it's not real, and she was a fraud.
I'm going to piggyback on that. I had one client that did an at-home Everlywell vitamin D test, and it said that her vitamin D was 92 nanograms per milliliter. And then we had a serum drawn at a lab, and she was in the teens. So how did that...
Oh, no.
It's not even, it wasn't even close.
Yeah, see, that worries me.
It really worries me. It
worries me. See, I say I don't know the accuracy because I haven't spent a lot of time looking into it, but just given the nature of the test, I'm a little iffy about it.
Yeah, I agree. I highly recommend, I would just go find a provider that'll work with you. So I hope that this episode brought some clarity and not extra confusion. We'll put in the notes a link to a list of these labs so that if you want to just have it all in one place in one little PDF, I have that really simply. And I think we should move on to our Yeah Girl.
Let's move on to our Yeah Girl. Okay, Caitlin,
I think one of the biggest...
Am I doing the horse vagina Yeah Girl?
I think one of the biggest Yeah Girls is that this is our season end. Yeah, girl.
This is our season end.
And that's fun.
Yeah, girl, we did it. And yeah, girl, you can't tell, but Caitlin and I are wearing the same color shirt today, too.
We're like sisters.
I guess mine's a little more blue than green than yours.
In a different place.
Sort of matching. Sisters across the country.
Yep, another season.
That's a good Yeah, girl.
In the wraps. And we are already starting to record the next season. So there shouldn't be an incredible time lag, hopefully, between seasons. And so that's another Yeah Girl. Look at us, like, already ahead of the game.
That is another Yeah Girl. We're doing it. And we have some really, really exciting guests lined up for this next season. We have got people, all of your most burning questions, every bit of feedback you've given us. We have got practitioners coming in here talking about men's sperm health. We've got people talking about vaccines while trying to conceive and pregnant. Very hot topic, giving you the information that you need on that. We have surgeons coming in talking about surgical options for things like opening tubes, endometriosis, adenomyosis, Asherman syndrome, all those things that you guys might be having. We could go on and on. We have a lot of really exciting stuff to support you. It's going to be a really fun season. There's going to be a lot of really awesome guests, awesome information, more of Caitlin and I. And beyond that, we've just got a lot of exciting stuff lined up. A lot of exciting stuff.
So stay tuned.
It's going to be off the hizzity. So stay tuned. Yeah.
I don't know if you've looked at reviews lately, but there have been a few that have come up in the last couple of weeks that have been really sweet. And so because I spent time reading those reviews and they made me really happy and brought some energy to some of our recent recordings, at least helped me bring my energy. I highly recommend, if you're listening to this, that you go do that for us, because if we're helping you, we want to know, and we want others to know that this is a free resource for them.
Amen. Amen. And Caitlin has some really exciting professional things going on. We're going to have more about that in the future too. There's a supplement line. There's an app. She's just busting down all the walls. She's going to be the PCOS guru across the world. I am very excited for what she's got going on. She is supporting sisters with PCOS the way that just no one else I've ever seen has done, with her kind heart, with her sweet voice, and with her just all this energy that you love about Caitlin, which keeps you coming back.
Oh, you're too kind.
Keeps me coming back. I wouldn't be doing this if it wasn't for you.
You know what's fun about this podcast? This will be my official yeah girl. That Sophia and I have just like this sweet, sweet friendship. And I feel like the podcast helped us kind of walk into these really cool career callings for us, like in a more full way. And that sounds super woo-woo, but I do feel like it's kind of catapulted some things in our own.
And we've been learning so much as we go as well. This podcast, I mean, these guests that we have on, sometimes it's someone that we have on and we're asking these like very leading questions, like, why should we be eating vegetables? You know, like Caitlin and I know the answer to that. But sometimes we have guests on that blow our freaking minds. Like when we had Dr. Whitaker on talking about surgical interventions for all these fertility things, that absolutely changed the way that I refer. That changed the options that I give my patients. It has been incredible. So we're learning, we're growing, and we're becoming better practitioners as you're learning and growing too.
Mm-hmm. So cool.
It's been beneficial for both of us. So that's Caitlin's yeah girl. What's my yeah girl? I think my yeah girl is that Jenny's about to crawl.
Aww.
That's my yeah girl. Is that my littlest baby is almost crawling.
That's a fun way to end this season. The episodes have all been like, Sophia's out because she just had her baby. And then other episodes are like,
she's pregnant. She's out because she had her baby. Here's her birth story. Now her baby's crawling.
Or we hear her sweet little nursing. Yeah.
Now her baby's crawling.
Now her baby's crawling.
Oh, yeah. She still does lots of nursing. She is the weirdest baby. She doesn't nurse to sleep. Like, who's ever heard of a baby that doesn't nurse to sleep? She does not. She wants to be left alone in her bed to go to sleep. Then the more I, like, jostle her and rock her, the more she's like, let me sleep.
That's how I am.
So weird. But, you know,
don't touch me.
She's an independent sleeper. I'm a little bit like that, too. Yeah, I know.
It's just she's starting early.
She's starting early, Miss Independent. All right. Well, thank you for listening to this episode. We are Caitlin and Sophia, your fertility bestie dietitians. Give us a review, rate the podcast, subscribe so you never miss an episode, and tune in next time for next season, which is going to be awesome.